I would speaker, Dr. Sanjay Jain. He is a director of Center for Infection and Inflammation Imaging Research and the vice staff for Basic and Translational Research, Department of Pediatrics at Johns Hopkins University. He is also a professor of international health at the Bloomberg School of Public Health. His areas of clinical expertise include pediatric infectious diseases, tuberculosis and mycobacterial infections, and international health. Dr. Jain serves as the director of the Center for Infection and Inflammation Imaging Research, and he's also a core member of the Center for TB Research at Johns Hopkins. Born in Halifax, Canada, Dr. Jain grew up in India, and he received his medical degree in 1999 from All India Institute of Medical Sciences, AIIMS, in New Delhi, where he was a house officer in neuroradiology. He trained in pediatrics at Penn State Children's Hospital, Milton, Hershey Medical Center, and the Tufts University School of Medicine. He was a clinical fellow in pediatric infectious diseases, Johns Hopkins, before joining its faculty ranks in 2005. He was named as the Associate Professor of Pediatrics in 2011 and became the Professor of Pediatrics, Radiology, and Radiological Science in 2017. So there are several areas of research interest for Dr. Sanjay Jain and his group: cellular and low-cost technologies to improve healthcare, CNS tuberculosis, imaging for infections and inflammatory diseases, mycobacteria, pediatric tuberculosis, and tuberculosis of adults are all part of the research interests of this group. The major focus, however, is on pathogenesis of infections with the special emphasis on bacterial high containment pathogens that includes Mycobacterium tuberculosis, which is the causative agents of tuberculosis. And recently, the SARS-CoV-2, which was the causative agent for the COVID-19 pandemic that shook the world. Dr. Jain's laboratory utilizes small animal models and cutting-edge molecular imaging technologies to develop and test novel radiopharmaceutical imaging methods like CT, PET, SPECT, MRI to study disease pathogenesis, as well as to develop precision medicine tools for the diagnosis and monitoring of infections. They have the unique capacity to image animals infected with high containment pathogens up to biosafety level 3. Several novel traces developed in his laboratory are now being tested in first-in-human studies. Dr. Jain is also involved with developing innovative technologies to improve childhood immunizations and health of young children in the developing world. Dr. Jain is funded through several NIH and other grants. Notably, he is also the recipient of several awards, the prestigious NIH Director's New Innovator Award in 2009 and the NIH Director's Transformative Research Award in 2014. He is a founding member and past chair of the Infectious Diseases Subgroup and current board member of the World Molecular Imaging Society. He serves as a reviewer for multiple scientific journals and NIH study panels. He has a rich track record of high-impact publications and several patents to his credit. I will just read out a couple of them for the benefit of the young audience. A patent on mycobacterial polypeptide for use in producing vaccine to prevent gram-positive bacterial infection, and another on bacteria-specific label substrates as imaging biomarkers to diagnose, locate, and monitoring infections. So it is a great happiness and an honor to welcome Dr. Sanjay Jain to today's edition of webinar, and he is going to talk about what lies ahead for infection imaging. Over to you, Dr. Sanjay.
Well, thank you, Dr. Maheshwari, and Dr. Krishnan for this great introduction. I mean, that's very generous of you. I will just say very quickly that I am actually a practicing infectious diseases doctor, and majority of what we develop in the lab is to be able to help patients ultimately. And so I'm very excited to be able to talk to a lot of folks here who are, I'm assuming, have a background in radiology, nuclear medicine, but also infectious diseases, and kind of give a broad overview of infections. Although a lot of our work is done on TB, I'm going to talk a lot about other pathogens that we've worked with recently to give a broad overview. But again, TB is what we do a lot of work on. So I'm going to switch and I'm going to start sharing my screen. Please let me know if you can't see my screen. Give me 1 second. Sorry, it took a little bit of time. Can everybody see this?
Yes, now we can.
Excellent. So, um, so I'm just going to quickly give an overview. I have about 40 slides or so. A lot of this data is published, so I'm going to try to talk about mostly conceptual stuff. I also talk a lot about pathogen-specific imaging, as that's quite interesting. So these are my disclosures. So I don't really need to bring this to the audience here, but infections remain a major cause of both disability as well as mortality in the world. And the question that I always ask of the scientific community is, there is a lot of uh, need for newer technologies in infectious diseases, and are we applying all the modern technologies that are coming up for infectious diseases? So about 12 years ago, we established the imaging of infection subgroup at the World Molecular Imaging Society, and a lot has been achieved since then. And I want to talk a bit about some key concepts that should be considered for pathogen-specific imaging approaches, that is, approaches which can specifically diagnose infections. But I also want to talk a bit about how we can translate them quickly into the clinic. And I think that's where your help would be very, very important. I mean, I know the Indian medical system a bit, but I also know that technologically as well as clinically, it is extremely strong. And so a place that could, in theory, do all of this work would be a place in India. And what I would like to do and hope through this presentation is that this spurs interest in actually doing some of this work, not just preclinical, but also actually taking either what is already being developed and is being tested, and I'm happy to help with that, or developing new technologies and taking them into the clinic. Because I think that's where the rubber meets the road, which means that's where, we will really know if what we have developed works or not. So, what are we talking about in terms of pathogen-specific imaging? There's a lot of interest in pathogen-specific imaging. This is a slide which has some important papers that have been published. There's a lot of interest since we set up the imaging of infection subgroup. Um, and I'm very happy about it. First of all, this is not an inclusive of every publication. This is just some papers that I know about. But also papers where there have been clinical studies which have been done with new tracers that have been developed. And I think that is very critical. And there are obviously limitations of nuclear medicine, which a lot of us know. And I think we need to understand how we can overcome some of those limitations in trying to solve logistical problems of how we could use this clinically. So one thing that we have talked about a lot is that if you want to develop something which is pathogen specific, it really needs to concentrate, not just have a high binding affinity, but concentrate within the bacteria or the pathogen of interest. And this is because, for example, in bacteria, they're much smaller than a standard mammalian cell. And they're about 1,000 to 100 times smaller. And so we really need that tracer to accumulate highly just to be above background. And that can be achieved by having either multiple binding sites or having an enzymatic trapping mechanism. So that's very critical. I'm going to also introduce another new concept that we have talked about in the in the past, but I'll show you some data to support that. So switching gears, many years ago, my group did a random search of about 1,000 molecules that were kind of random, small molecules that we thought would be specifically taken up by bacteria or other pathogens, but not by mammalian systems. And we did an in silico screen first, which means we asked a question, is this known to have a bacteria-specific or a pathogen-specific metabolism? Is it accumulating in bacteria or pathogens? And does it have eukaryotic or mammalian metabolism? And if it did have mammalian metabolism, that was not good. But if it did have the other two, that was good. And so then we took the high scoring molecules and then we incubated them with different species of bacteria. Staph aureus here for gram-positive, E. coli gram-negative, Pseudomonas, another gram-negative, mycobacteria. We used both smegmatis and TB, and then macrophages as control, and we used heat-kill bacteria. So this is a very seminal paper. A lot of the molecules that are on this paper are being developed by us and by other groups. I'll talk about para-aminobenzoic acid, which is a precursor to folate, also a target for a very big class of antibiotics called sulfonamides. And then there are several other molecules that are taken up by specific classes of bacteria. One that we've developed quite a bit is sorbitol. And I'll also tell you an interesting story about sorbitol. And then there are other people who are developing others like cellulobios and then mannitol that we've developed. So this was a very important paper because a lot of new molecules came out of this study, and they're being developed by a wide range of groups. So our goal has been pretty broad. One is we want to specifically detect and localize a class of bacteria or a class of pathogens. And so para-aminobenzoic acid, for example, can localize all bacterial classes that we have tested. Identify a specific fungal group causing infections. I'll show you some data with fluorodeoxysorbitol. We developed it initially for bacteria, but actually somebody else told us, and I'll show you some of their work, that it could be used to image fungal infections, and we've done some work there, and then rapidly detect therapeutic failure. So if you can repeat imaging in the same patient very rapidly, you can get answers about if a regimen is working or not based on the change in the signal, which would not occur with, let's say, CT or other methods, because CT and other methods are looking at inflammation and not the bacteria themselves. So sorry, I'm just going to quickly talk about some of the work that's been done. So this is para-aminobenzoic acid measuring Staph aureus implant infections. This is the PET-CT in a rabbit model, and then you can see this is also something that has bioluminescence, this bacteria, and we can co-localize the bioluminescence. We've done some first-in-human studies in healthy volunteers to show that PABA was safe. And then we have done more recently work in a mouse model of M. abscessus. So M. abscessus is pretty prevalent all over the world and causes infections in immunocompromised patients and those with underlying pulmonary disease, especially cystic fibrosis. And in this paper, what we show is using a mouse model and then some human studies that we can use PABA to localize infections because of M. abscessus and differentiate it from underlying sterile inflammation, which we induce with LPS, which is lipopolysaccharide. And then we can also monitor response to treatment. So if you treat these animals effectively, the signal goes down. If you don't, then the signal remains the same. And then we've tested several clinical strains, including those which are highly resistant, and shown that PABA goes into all of these different clinical strains. We've also done imaging in a patient who had confirmed mycobacterial abscessus disease, or mycobacterial, and there's another name for it now. And we can localize these infections, these infectious spots, using PET imaging. And interestingly, not all the lesions that were visualized in CT were also seen on PET. Switching gears to fluorodeoxysorbitol. So this is a sugar. This is our first paper on this, where we used it to measure, to image Enterobacteriaceae, which is, or they're not now called enterobacterials, include E. coli and other gram-negative bacteria. You can see here a mouse that has on one side live bacteria. I don't know if you can see my cursor, but it's a yellow arrow, and then tenfold higher dead bacteria. We intravenously inject FDS, goes to all parts of the body, but it localizes at the site where there is live bacteria, but not at the site of dead bacteria. And you can see that very low background. But FDG will not be able to do that because dead bacteria cause a lot of inflammation. And so the signal is essentially the same. We did a clinical study where we prospectively enrolled patients who had these infections compared to those who had cancer or other pathologies, and we showed that the infection, that this method could reliably diagnose the infections because of this class of bacteria and differentiate it from cancer or other pathologies. We also did a follow-up scan that showed that there was a reduction in the signal, but also want to point out that this is just the data where we're showing sensitivity and specificity with a target to non-target cutoff of 3, and we can talk a bit about what that target to non-target ratio is. We were able to have a very decent sensitivity and very high specificity for this approach. So this is just an example of another patient who had cancer, but also had Klebsiella pneumonia infection. So on one side, there is FDS, the sorbitol PET, which was done for research reasons. You can see these arrows lighting up the infection. And then this patient also had an FDG, the glucose PET, for clinical reasons. And you could see that there are lots of cancerous lesions that are picked up by FDG, which are not picked up by FDS, and just an example of that. More recently, a group in South Korea demonstrated that sorbitol can be taken up by mold infections. This is quite important because molds are a very important cause of disease in cancer patients, and that is a cause of very high mortality. And currently, methods to diagnose them are not very good. What was confusing about that paper was that, we know that E. coli had a lot more uptake for mass to mass, meaning if you normalized it to the mass of E. coli versus the fungi, E. coli had a lot more uptake. But even then, FDS was able to, in animal models, image fungal infections. So we hypothesized that this may be because the amount of biomass of fungi in the lungs or in a clinical infection is substantially more than when you have a bacterial infection. And we were correct. So we took biopsy samples from patients who had Aspergillus, and we showed that the biomass of Aspergillus in these infections is quite high. It's around 12%, whereas for a bacterial infection, even when they're 10 to the power 7 bacteria per ml, only 0.24% of the lesion is actually occupied by bacteria. Again, pointing, I started by saying that bacteria are very small. And so majority of the lesion is filled with still, fluid and white blood cells. But the biomass of what is there is very low. So this is a very important concept. One is, how much uptake is there of the tracer in vitro, but then we also have to understand how much biomass of the organism that we're trying to measure is inside the human body when there is a clinically relevant infection. And so we tested all of this in also relevant animal models, and we showed the same thing. So this is the paper that I was talking about that was published by Dr. Min's group from South Korea, that FDS could be used to measure invasive aspergillosis in animal models. So in addition to doing some preclinical studies, we also started a prospective study in humans to test if we could measure this in humans. And so indeed, one thing I want to show you here is that there was massive uptake of FDS in all the different clinical strains that we've tested. I think we tested about 31 different strains of not just Aspergillus, but a wide range of invasive mold infections. So this is kind of new data. The other is I want you to see, how much uptake there is. So For E. coli, the uptake is generally around 10,000 becquerels per milligram. For these, it's still about 2,000 becquerels per milligram. There are other tracers that are being developed, and I think the uptake for the other tracers is extremely low, and I think they use other methods to show how much uptake there is. But what I'm trying to tell you is if you do really a head-to-head comparison and look at actually the data very carefully, sorbitol has a decent uptake even in mold infections, which means that other tracers that are being developed for molds don't really have this much in terms of becquerels per milligram uptake. There's some controversy about this, and so you'll see data from different groups, but we've verified this data multiple times now, and we kind of stand by this. And I would just argue and encourage you to think through this. I know this is a technical point, but I just want to point out that I think FDS is probably the best tracer right now for any invasive fungal infection, including anything else that's being developed. The other thing that we really looked at, and I'm going to skip through this very quickly, you'll have to believe me, is that we incubated FDS with these fungi in vitro, and then we took the cytoplasm to see if it's being metabolized. So we now know that FDS, sorbitol, is being metabolized by fungi intracellularly, and it's, we believe, converted into fluorodeoxysorbitol 6-phosphate. Which is exactly what it is in E. coli also. And so that's a very important thing, that it's not just like, binding to the surface non-specifically, it is being metabolized very specifically. So I'm going to skip through this, but this is animal model data that shows that fungi, these fungi have good uptake in the lung model, they have good uptake in a nasopharyngeal model, and then also in a brain model. So this is now human data. So on top, you see a patient with mold infections, and you can see uptake a lot in the lung. And then there's a control patient who has sterile inflammation, and you can't really see much FDS uptake. This is the animal model where we've injected aspergillus in the brain and FDS intravenously, and you can see a very nice ring-enhancing lesion here. And then you can see a patient who had aspergillus and has a very nice ring-enhancing lesion there also, and there's none in controls. This is another patient who had cancer, breast cancer, and I'm just showing an FDG scan, showing it as a target to non-target ratio. The target to non-target ratio is the ratio of the signal at the site of what we think is lesionous divided by the signal noted where there is no lesion. So generally, if it was a lung infection, we would look at the contralateral side of the lung. And so that's what we use SUV has several problems. It works well for FDG, but not for all other tracers. But here we're showing this breast cancer patient. You can see signal. We showed either target to non-target or SUV. You can see a nice signal on FDG PET. The same patient gets an FDS PET. You can see very nicely that there is no signal from the cancer lesion. So again, trying to show that sorbitol is not being taken up by cancer cells substantially, and that it's a really good infection specific imaging agent. Another interesting thing that happened was a patient who had an infection because of Cladophora bantanyi. It's a mold that causes infections in the lung, but it has a propensity to go to the brain. So this patient we knew had lung infection, but we did not know that this patient had a brain infection. But we knew that it goes to the brain. So the clinical team had done an MRI for this patient, and the MRI was initially read to be normal. When we did the FDS PET, we found a lesion, as you could see here. I don't know if you can see this very well, my cursor, but there's a lesion in the brain, in the frontal parietal area, and when we then went and looked back at the MRI, there was some lesion there. This patient also had brain lymphoma, so that's the reason it was difficult to make that diagnosis on an MRI. So based on this, we think that our method is not only highly specific, but maybe very, very sensitive, and more sensitive than the best methods that are available. This is a small study that we did, only about 5 patients, but we want to do a much bigger prospective study. So I wanted to quickly talk about the valleys of death. So, when you're trying to develop something new, there are 2 big valleys of death. There are several valleys of death, but there are 2 big ones. One is from preclinical development to clinical research to show that, okay, well, this is not just something we see in a mouse, but we see the same thing in patients. And so we've kind of crossed the first valley of death for many of our tracers. The second value of death is saying, okay, this works in humans, but can we use it to change clinical practice? And that's where I'm very, very optimistic, especially with this tracer for FDS for invasive mold infections. I think that it will change clinical practice massively, because if we diagnose infections early, we can save lives of these cancer patients. In fact, like 1/3 of the deaths in patients who have some form of leukemia is because of mold infections. And the sooner you diagnose them, the better it is. And it's a very complex diagnosis. So one thing that we have done, we pioneered it, and I know others have followed, is that we can make a lot of these tracers easily. So in the US one, PET has not been very commonly used for infections. That's changing right now. But the other thing that's happening is that we have developed methods to make a lot of these tracers very easily. So FDS, for example, can be made about 10 or 15 minutes from FDG, commercially available FDG at room temperature. So that's a big advantage, so that you don't need a cyclotron. You just need a supply of FDG, and where there's a PET scanner, there's FDG. So there are other people who've developed methods to do this with their tracers. So I just wanted to, point that out. There are several groups, including from UCSF, NIH, in another group in the UK, that have developed enzymatic methods to convert FDG into their tracer of interest. Enzymatic methods may have some trouble to scale up, though I think that there's some promising results, but our method is chemical method, and so it's very easy to adopt, anywhere in the world. I'm going to switch gears. I have talked a lot about pathogen-specific imaging, and I want to spend the last 10, 15 minutes of my talk on what we've done a lot with TB, which is to measure the concentration of the antibiotic at the site of infection. So the question really is, does the drug, which is the antibiotic, get to the bug, which is, the infection? So we've done most of this work in TB, but we have, extended this to other infections. And the fundamental concepts here are as follows: that, we know a lot about how we can inhibit the growth of bacteria or other, infectious pathogens inside a test tube. But we also need to know, when we give these drugs either orally or by other methods, that they achieve the concentrations above what is called as a MIC in the body. In animal models, we can obviously test that, because we can kill the animal, we can take that tissue and measure the drug concentration, but you can't do that in humans. And so mostly, the human data is not as easily available. And so we often, when we're giving drugs, we don't know what dose should be given to make sure that the concentration of the antibiotic is high enough. And so what we have started doing is we've radio-labeled several antibiotics in a way that they remain chemically identical to the original antibiotic, and we do whole body imaging, and we basically get information. We do dynamic scans, so we get information on time and concentration, so AUC, and it's unbiased. So we get information in multiple different compartments, and we can do this in several different patient populations. And so this has been a very interesting approach that we have used. And I'll give you an example. This is with rifampin, which is labeled with carbon-11. And this is a mouse that was injected with carbon-11 rifampin. This mouse is rotating. And this is what we call as a 4D image. But this will happen again. So this will loop back. So you see carbon-11 injected intravenously. Rifampin goes to all parts of the body, very quickly goes to the liver, and then you'll see this hepatobiliary excretion of the rifampin. So the rifampin here, the carbon-11 version, is behaving pretty much like what standard rifampin would behave like. And we've done a lot of work, and we've shown with others that rifampin has been underdosed for a long time. And I think a lot of people have known that, but we've now experimentally shown that the concentrations that are achieved in animals, but also in human tissues, are much lower than what is what was taught for rifampin, and that higher doses need to be done. So this is a very interesting method, and we've used this for a wide range of diseases. We've used this for TB, meningitis. We've also shown that the concentrations of the CSF have no relationship to the concentrations in the brain tissue. So, there are a wide range of things that we're trying to point out here. One is that, the concentrations are low. Two is that clinical specimens or samples that we think are relevant. For example, we often look at the CSF or the cerebrospinal fluid as a surrogate of what's happening in the brain, but that's not accurate. And that's something which is not entirely new. If you talk to oncologists, they have always thought that the brain and the CSF are very different compartments, especially when they're looking at brain tumors. So I just want to point out that that this is a very important thing that we should be aware of, that every compartment that we're looking at is not the same. The other thing I want to point out here is this graph, which is on the bottom left, where we're showing that the concentration of rifampin, or the amount of rifampin that's going into the brain, is changing pretty rapidly. Within 2 weeks of actually starting treatment, the amount that's going into the brain decreases rapidly. For TB meningitis, we gave rifampin for 12 months. So within 2 weeks, the amount of rifampin that's going into the brain has gone down by almost 5 to 10 fold. So, what is the amount that's going in at the end of therapy? We really don't know. So I think, again, very important to know that that there's a lot of dynamic changes that are happening in how antibiotics are getting into different tissues, but also the same tissue, or the same, for example, in the brain, different parts of the brain will get different concentrations. And a lot of this is not rocket science. It's based on the blood flow to different parts of the brain. So I think, these are all acceptable things that if we think hard about them. But again, coming back to what this means to the patient, we often need to be careful about getting data from samples or compartments that don't reflect the compartment that we're measuring. Here, for example, CSF is not equal to brain. So we've also done this with infections in the bone for Staph aureus, and shown that bone concentrations for rifampin are also much lower. And then more recently, we've done a very extensive study where we've looked at 3 new antibiotics for actually 4 new. One is not as new, but for TB, which is MDR TB, we've tested predominant cetazolid, linezolid, and bedaquiline. And we've done a lot of work with these antibiotics and shown that their penetration into the brain is quite different from what is in the lung, and their activities in terms of how well they kill the bugs is also very much related to the concentrations they achieve in different parts of the body. So this is a very interesting paper. It's a huge paper. It has a lot of data in it, but it tells us a lot about why certain drugs will work very well in the brain and certain drugs which will work very well in the lung, and and they correlate very well with the antibiotic concentrations. I want to end my talk with a little bit of information on some newer things that we're doing with imaging. So this is looking at markers of apoptosis. When TB causes infection in any part of the body, well, actually, it's just not TB. Most bugs, they cause necrosis, but MTB is extremely well known to cause necrosis, and it also inhibits apoptosis. So apoptosis is well-controlled cell death, whereas necrosis is uncontrolled cell death, where there is obviously a lot of debris, and MTB likes that because it's very nutritious and it kind of thrives well in that. So there's a lot of interest from our group, but other groups to use pro-apoptotic drugs that would move away from necrosis to see if we can improve TB treatment. So this is some data that we have recently published, and we're very interested in this, is to use a drug called navitoclax, which was in clinical trials, and there are other analogs of this, venetoclax, etc., which are anti-cancer drugs because they promote apoptosis, and they have been used, in the clinic, and some of them are approved clinically for cancer. They're adjunct cancer. They're not like major chemotherapeutic agents. And so we have used these agents in TB, and we've shown that they improve treatment. So here, what you're seeing is um, a mouse model animals where you can see that there are animals that have gotten treatment, that are not treated, and then they've gotten treatment and gotten this pro-apoptotic agent. And we have an imaging agent called ICMT11, and we've been able to use this to image the amount of apoptosis that's happening in live animals. So at the bottom, you can see when a pro-apoptotic agent is given, there is a much higher apoptosis, and you can see that light up in the lung. I don't know if you can see my cursor, but that's where it is. And so we can do that, and we can also measure fibrosis. We have a tracer for fibrosis. And interestingly, when we give this pro-apoptotic agent, it decreases fibrosis substantially. And that is both because of its pro-apoptotic effects, but also it has some anti-fibrotic effect, which we knew when we started this work, but it's kind of interesting because post-TB lung disease, which is now being increasingly recognized, which means, you treat a patient who has TB and they get better because you kill all the bacteria, but they have substantial underlying lung disease, mostly mediated by fibrosis. And so it's not fully understood, but people think about 50 million people currently have post-TB lung disease. So a lot of these have been cured of TB, but they have bad lungs. And the question is, can we prevent them from developing this lung disease? And one way would be to prevent fibrosis. And so here we show that this drug, navitoclax, can prevent this fibrosis, and then we hopefully think help with post-TB lung disease. We're doing a lot of work on this. This paper was published earlier this year. We show that when we give navitoclax and increase apoptosis, you can also decrease extrapulmonary dissemination of bacteria. We can also decrease the relapse rate. So it has a lot of other benefits that we initially did not know about. And so we're working on this. And our goal is to translate this into the clinic. We have a clinical trial ready to look at fibrosis in post-TB lung disease. I would encourage you that, if that's possible, to collaborate with folks in India. So I kind of want to summarize some of this stuff, but also kind of talk about most important things going forward. So I think there are definitely pathogen-specific approaches that can be developed for detecting bacteria, but for other pathogens. And this could be clinically useful for a wide range of things. I am very excited and interested in using approaches to detect invasive mold infections. I think we have done some small studies with this, but we would like to do larger studies. So if there are groups that are interested in working with us to test FDS for mold infections, we'd be very happy to. It's very easy to make, so it's not that difficult, and it could be done anywhere in the world. So we would definitely be very interested in doing that. We're very interested in looking at antibiotic penetration into different areas, and as new antibiotics come, we will continue to label them to understand what their pharmacokinetics are, where they're going, and where they're not going. And this is, we've done a lot of this work with TB, but this is widely applicable to a lot of other infections. And then the other thing that I want to point out is that we remain very interested in testing newer agents, things for post-TB lung disease, for fibrosis, apoptosis, and actually use them as what we would call as adjunct markers. So, a lot of drugs, when they go from preclinical to the clinical world, fail. And they fail often because either they did not have a biological effect, or two, because they did not get there at all. So, how do we know that? And, often the clinical trial is done and it doesn't work. It worked really well in animals, but it didn't work in humans. So how do we know that? And how do we figure that out? And so we are interested in therefore doing adjunct studies in patients with imaging to make sure that, if there is a pro-apoptotic agent, is it actually causing apoptosis in the lungs or not? And obviously, if it's not, and we see no apoptosis, then we know that, there was the biological effect didn't occur, and that was the reason it didn't work. And then obviously there could be pharmacokinetic reasons or other reasons for this. So we remain quite interested in that. So I think I purposely left some time for questions, and I'd love to, answer questions, but I think this could be a very good opportunity to work and collaboratively with folks in India, and take some of this work that's been developed in my lab, but in other labs, and actually apply it to clinical studies. I want to thank all the people in my lab, all the collaborators. This is a lot of different people who've done work, mostly in my lab, but also our collaborators who've done a lot of work and made this possible. And then thanks to the NIH that has supported all our research, which is critical, as well as the U.S. Department of Defense. So I'm going to stop here. I know we have about 15 minutes or so for questions or discussion. So back to Dr. Krishnan, I guess. Yeah.
Thank you, Sanjay. That was such a wonderful talk, and I think very inspiring. Now the floor is open for questions.
Hi, Narinder. That's a wonderful talk, Dr. Jain. It's a very, very interesting talk. So I would say I could probably converse with you for nearly an hour. I have so many questions because it's such a new field. But the couple of things which comes, you being ID, practicing doc, so you still need the microbiology diagnosis, after doing the imaging, or how do you choose your agents for these clinical trials from going phase 1 to phase 2? Where to use FAPI, where to use sorbitol, where to use the 14C and 3H kind of thing. Uh, and so that's my first question. The second question is, I believe from your talk, I gathered that you have a total body PET when you do the dynamic imaging throughout the body. And, and I may be wrong. And the third thing, Dr. Jain, I would, uh, you know, I'm a cardiothoracic radiologist and I do nuclear medicine too. Uh, the third thing is basically what in immunosuppression patient, when there is a lymphocyte mismatch or triggering between T cells and B cells, how do these agents behave? Is there any work on that, how to distinguish between infection versus rejection? Is there any way? Because that's my biggest worry, kind of thing, first 100 days infection, 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 and after that rejection. So these are my three-part question.
Yeah, thank you, Dr. Gupta. So I'm going to take the questions from easiest to the most difficult. So question number 2 is probably very easy. We don't have total body PET. We do what is called as a multi-bed position dynamic PET, and that's how I was showing you data for dynamic PET. Majority of in animals, obviously it is like a total body PET because the animal is quite small. So technically, the mouse fits into the PET rings completely, and so you get total body PET. But for humans, we use a multi-body protocol, so it is not technically dynamic PET because we're passing different parts of the body I'd say every 10 or 15 minutes or so, or sometimes sooner, depending on what protocol we have. Let me tackle question number 1 first. So I think I talked about a wide range of tracers, and some of them are pathogen-specific imaging agents, some of them are to study antimicrobial pharmacokinetics, and some of them are to understand pathogenesis. And so the use of these tracers is going to be dependent on what we're trying to do. So for example, the tracers for pathogenesis are more likely going to be used when a new drug is being developed or a new class of drug, for example, a host-directed therapy, apoptosis, and they may or may not be useful as much in routine clinical use. They may be. I mean, there may be a tough patient where you need to understand if this drug is getting there or not, and that would be useful. The antimicrobial work that I showed you, where we've radio-labeled antibiotics, I think that also is going to be critical in situations where new drugs or even existing drugs are being developed, where we need to understand how to dose them. I think a lot of the work that we have done has now helped at least come up with a dose that we would use in clinical studies. But that work, the antimicrobial pharmacokinetic work, could be useful in difficult patients. Sometimes we have very difficult patients where we don't know if a drug is getting there. You're a cardiothoracic nuclear medicine person. We have very complicated infections in the cardiothoracic area that I have to treat. And I don't know if the patient is not getting better, if they have drug-resistant bacteria or something else, or if the drug is just not getting there because there's so much fibrosis from post-surgery, et cetera. So that's where I think those could be used. The pathogen-specific imaging agents are probably going to be very useful in routine clinical use. I think your question about which one to use is a very good one. I think I can think of, at this point of time, two big indications. I think for invasive mold infections, at least the pathway right now that is set up for immunocompromised patients is if they have fever for more than 5 days, you empirically start them on antifungals. And molds are the most important bugs that you're looking at. So at that point in time, they start doing CT scans. They often do bronchoalveolar lavages. And that's where I think this technology could come in really well, because you could find out if they have a mold infection or not. If the scan is negative, you could rule it out because it seems to be highly sensitive. And if it's positive, then you may do a bronchoalveolar lavage and find out, what kind of mold infection it is. And you may not have to do that because generally the question is, does somebody have a mold infection or not? The other time when these scans could be very useful is when you're trying to convince a surgeon to say, well, can you biopsy this patient because we think they have a mold infection? And the surgeon is like, this is a high-risk patient. We really don't want to do that. But if you had a scan that's positive and says, this is where the mold infection is, they can go and biopsy it, and then they can get more information. But from a very big picture version, knowing sometimes that if there is an infection, a bacterial infection or not, or if there's a mold infection or not, itself is very critical, because we want to make sure that there is no cancer underlying that. So that's question number 2, meaning your question number 1. But because of time, I'm just going to spend a very few minutes on the last question. I think the last question was about immunology and rejection in patients who have transplant. And are there technologies that can help differentiate whether this is an infection or an immunological process? And the short answer is that there isn't any technology right now. The other problem with rejection is that rejection is mostly, if I'm correct, mediated by, when it's an infection, it's mediated by viruses. And, the imaging methods for viruses are going to be different than for bacteria. But there are a lot of imaging methods now to look at immune responses. And there's also a lot of interest in, I don't know if CAR T cell therapy is being used extensively in India or not, but to track those cells. So I'm going to stop here. I know these are absolutely great questions, and there would be a lot of interesting conversation which we could have offline, but I hope that I answered some of your questions here.
No, thank you. Thank you so very much, Dr. Jain. It's very eye-opening, future into the infectious disease, which is always a bane and pretty disturbing to the patients. No, thank you.
Hi, I'm Dr. Halkar from Emory. Thanks for such a paradigm-shifting research. One thing I want to try to explain, say that nuclear medicine or radionuclide imaging has slowly been moving from diagnosis and treatment response to therapeutics. So is there any role that, just like in oncology, we have moved from diagnosis to localization or treatment response to therapy? Is there any chance any one of these agents can be used in drug-resistant bacterial infection?
Yeah, that's a great question. Yeah. Yeah, and I also want to acknowledge Dr. Halkar. There is somebody else who has their hand up, which is I think Dr. Sanjay Gambhir. But I will first answer your question, but I just want to make sure that I acknowledge that I see at least one hand up. So I think what you're talking about is theranostics, and I think it's really, really hot right now. Um, and um, I think that um, theranostics is very, how should I say? It's it's well accepted in cancer because radiotherapy and other ways of killing cancer cells is well accepted. At this point in time, most infectious diseases, people don't want to kill bacterial infections with with radiotherapy, partly because we still have pretty good antibiotics for a wide range of things. Although I think with drug-resistant infections that changes. The other problem with bacteria, unlike mammalian cells, because oncology, the cancer cells are still mammalian cells, um, because of the very thick cell wall of bacteria, they are a lot more resistant to radiotherapy um, than conventional mammalian cells. So you would have to think about delivering a much higher dose locally to do that. However, I want to tell you one other very interesting thing that's happening, and we are a part of it, where I think this approach of theranostics is viable. So there is a very big field that, still kind of it's a research field, but it's we don't know if it's clinically useful at this point in time or not, is to use bacteria to kill tumors. And it's not that the bacteria eat up tumors. It basically is that bacteria uh, increase immune responses in tumors. And there's several mechanisms. One is that the cancer cells start expressing antigens from bacteria that they're infected with, and then the immune cells come in, eat them, and kill them. There, theranostics would be very, very valuable. And what I mean by that is that the bacteria are going to be used to kill tumors, and that's the theranostic part or the therapeutic part. But we have to track if the bacteria get to the infectious site or not. So we are very interested. We have published some papers on this, and I'm happy to send that over to you. I'm not trying to say that radiotherapy to kill resistant infections is not going to be on the anvil. I think some of the really resistant bugs do require antibiotics now that have high toxicity. And in those situations, radiotherapy may be a viable option. It's just that most of my colleagues will just beat me to pulp when I suggest that. But that is a culture change. So thank you for that question. I see that there are a bunch of other questions, but I will let Dr. Krishnan decide who I need to answer if there are questions coming up everywhere. So Dr. Krishnan, back to you.
Dr. Gambhir had his hand up for a long time. So Dr. Gambhir.
Okay, thank you for giving me the chance to talk. Can you hear me?
Yes, we can.
Yes, we can. Yeah.
Okay, Dr. Jain, nice presentation. So taking us through the pathogen-specific imaging to the kinetics for finding the concentration of drugs to be given and later, of course, the FAPI for the fibrosis or decide on that basis if we can give anti-fibrotic agents or whatever. So my main question and the moot question is, this is a revival of the field which has been, people have been working at it off and on and then leaving it in frustration because we can't find pathogen specific agents, so-called this. So what you highlighted was the FDS, fluorodeoxysorbitol. So how specific, how did you determine the specificity of this agent for the mold? Because what I recollect, it's also in literature, it also highlights the tuberculosis very well, as per my knowledge. So there is some work on FDS working on tuberculosis. So as you know, which thing you are suspecting mold infection, you try FDS in that clinical scenario, or like de novo when you are looking for the specific pathogen, it could be anything in infection. So after you run through some biomarkers, biochemical, and then you are choosing the thing. So my question is specificity of sorbitol for the mold. That is how we really nail it.
Yeah, so Dr. Gambhir, I just want to point out, I think you're probably confusing sorbitol with glucose, right? So there is no data
No,
on,
no, not at all. Not at all. So, yeah,
oh, so
sorbitol has been around. So there is, so people are trying in various infections. So that's why I'm asking you, how well
yeah,
the specificity.
I'm not aware of sorbitol being taken by tuberculosis. I know sorbitol is taken up by aspergillus. I mean, that's been known for some time, and we have shown that it's been taken up by a wide range of mold species. Um, but I'm not aware of data that M. tuberculosis also takes up sorbitol. M. tuberculosis takes other sugars. There is a sugar that has been talked about recently. It's called trehalose, and trehalose is also metabolized by fungi. And trehalose is a disaccharide. It's not a monosaccharide. Sorbitol is like glucose. It's a monosaccharide. So I would love to, if you can point out papers that suggest that sorbitol is taken up by TB. I'm not aware of any, but if there are, then I'm happy to learn.
No,
So
no
that's a question
problem. But
back to you.
how, yeah, no problem. But how is it specific for the mold? What is the mechanism behind it?
Yeah, so yeah, absolutely. So sorbitol is, so this is known in microbiology, right? So when you actually try to culture a mold, you use a plate that contains sorbitol. So mammalian cells cannot take up sorbitol. So sorbitol metabolism is very limited in mammalian systems. The two that I know are, one, it's made in semen, in very small quantities, and then when people have um, very bad diabetes, the some of the glucose gets converted into sorbitol and it causes problems with the lens, and that's one of the reasons people have diabetic lens issues, because sorbitol is really not metabolized, and that's one of the reasons why it causes lens issues, because it causes osmotic pressure, because it cannot be metabolized by human cells. So when glucose is taken up, it gets converted into energy. When sorbitol is taken up by mammalian cells, it cannot get converted into energy. It actually forms basically osmotic pressure there, and therefore destroys tissue. In molds, as well as in certain bacteria, sorbitol is taken up by a cassette called the sorbitol dehydrogenase cassette. It's a wide range of genes that control it. The first set of genes is taking the sorbitol into the bacteria or the fungi, and it gets phosphorylated there, and then it gets converted into fructose and others, and gets converted into energy. So that pathway is very well described. It was not known that if it occurred in other molds other than aspergillus, and we kind of show that, and we actually demonstrated that using some of the stuff that I showed. It's also published in the paper. So the mechanism is very straightforward. Mammalian cells cannot metabolize sorbitol, but certain bacteria and all molds we have tested can, and they use sorbitol as energy. Like we use glucose for energy, they use sorbitol for energy.
Yeah, thank you. Thank you.
Yeah.
Jane, I think there are a host of questions on the chat box. I think Jyotsna's question was already answered. She wanted to know, in the future, can theranostics be seen in infectious diseases like in cancer? I think it's very similar to what Dr. Halkar asked. And Dr. Sunita Naredi has several questions. She has three, in fact. Is it possible to differentiate active infection from iris, particularly in TB?
Yeah,
That's the
actually,
first
that's what we are most interested in. Actually, I think that would be another very important indication for developing pathogen-specific imaging, because it should be able to differentiate iris from, and I use iris very um, broadly because iris was defined mostly for HIV associated iris, but we know that there is immune reconstitution in TB where you don't need HIV. I mean, in India, majority of TB is in non-HIV infected patients, but when you start treating them, you start seeing tuberculosis growing through their brain, and they're having all of that stuff. So I just want to make sure that the iris I'm using very broadly because it's been defined in the context of HIV. But so I think that would be a fantastic indication. I think the biggest problem right now with a lot of these pathogen-specific tracers is the limited detection. We think that the limited detection could go down to around 10 to the power 5, so 100,000 bacteria per ml. That's still pretty high, right? It would be great for acute infections, but for infections which are percolating, it may not be a very low enough bacterial burden. So that would be the fundamental question. But I think that um, I I think that that is one thing that we want to apply this technology to. And so if you want to collaborate or if you want to give us some advice, we would be very happy to. TB and especially TB meningitis is one of my favorite topics. So I would be very happy to talk to you. I mean, just email me and we should set up a call and I'll tell you some of the things that we're thinking about.
Wonderful. So there comes Sunita's response. Would love to collaborate. But I will also read out a couple of other questions. I think the second one is more like a very interesting comment. In TB, there is a difference in the rate of reproduction of mycobacteria in various parts of the lesion. Would be interesting to see if there is a difference in uptake and penetration of the drug into that particular area.
Oh, that's a beautiful question. Oh wow, that's a very good question. The answer is yes. The flat out answer is yes, and it's not just because of the replication of bacteria, because the penetration of the drug is not dependent on the bacteria. It's mostly dependent on the host response, right? So, I mean, I think the biggest factor would be is there blood supply there, and then how much fibrosis there is, right? So if there is blood supply, then the antibiotic can get out from the blood to the tissue, and then if there's a lot of fibrosis, it will impede the diffusion of the antibiotic, and it depends on the physiochemical properties of the antibiotic. And physiochemical properties is it water soluble, is it fat soluble, is it protein bound or not? So this is actually a fantastic question. And actually, we have some interesting data on this. And I'm happy to refer you to some papers because, and we're not the only ones. There have been other people who've done two-dimensional MALDI or mass spectrometry to look at this. But we have also done what is called as autoradiography. So once you give these radioactive antibiotics, you can take the tissue and you can expose it to X-ray. And so you can get high resolution images, around 10 micron resolution. And there's a wide range of antibiotic concentrations in the tissue. So in essence, maybe just to summarize, there is heterogeneity at different people level. There is heterogeneity in different organs. There is heterogeneity within the same organ, and there is heterogeneity within the same lesion. So we need to embrace heterogeneity, and so that's a very good question. And we as a clinician need to embrace that and say, oh, well, this patient worked very well. I gave this patient 200 milligrams of so and so, but this patient is not. Well, lo and behold. So fantastic question. Thank you for asking that.
Yeah, the next one is also equally interesting. How do I decide what agent to use when I don't know the diagnosis?
Yeah, so I mean, I think that there are several ways to think about this in terms of what we're talking about and where we should use stuff. So, fever of unknown origin is a great example. So, fever of unknown origin is not just only an infection, right? I mean, it could be cancer, it could be a immunological or rheumatological disease, right? So, in those situations, people would use something which is highly sensitive but non-specific. So, for example, in that situation, FDG PET would be very useful because if the FDG PET is positive, then you know that there is something happening and you know also where it is, right? And so you could, in theory, one, if it's accessible, put a needle or, do a biopsy there. The other thing that we are trying to define is, so I didn't talk a lot about paraminobenzoic acid, but paraminobenzoic acid is taken up by all pathogens that we have ever tested because it's a very conserved process. It's my apologies. My kids are running behind, so I don't know if that's causing any disturbance. I have 3 young daughters, but my apologies for that. So para-aminobenzoic acid is taken up by every bacteria that we have tested, but probably other pathogens too. And so if you knew that somebody really had an infection, or let's say you knew that somebody had a bacterial infection, then you could use a PAVA scan and it would then light up any bacteria. And then, you would know that this is a bacterial infection. So, this field is still in its infancy, and I think, as pointed out by somebody else, it's gone through waves. There was a lot of interest, then things didn't work, it fell down, and then there's interest again. I think we need to do new things and we need to think creatively, and hopefully someday we'll have something that'll really work. So again, thank you for that question.
Thank you,
Uh,
Dr. Jain.
Yeah, I have a
I
few
don't-
comments, Uma. Just
Yeah.
this is Amol from Emory. Great talk, Sanjay, and very useful for our audience. Just FYI, the audience is actually a mix of both people in molecular imaging field in India and the US. I don't know if you're familiar, but there is a annual meeting of the Society of Nuclear Medicine India that happens every early December, and IASNM takes a delegation of speakers actually because we co-sponsor half a day of CME there, and we would love to get you there one of these years to establish collaborations and ties with the Indian community. We can help you connect to people there. This year it's too late. I think the program has already been finalized. It's December 4 to 6, but maybe next year. And I think next year the Federation of Society of Molecular Imaging is actually having its meeting in Hyderabad, where Dr. Sunita Reddy is actually based. She was asking you those interesting questions. So, that may be another opportunity for you to, establish these ties. So we can facilitate, and we are very interested in developing these collaborations between US and India. On another note, the topic was focused on bacteria and fungi, but a lot of interest has happened recently in this post-COVID world, where everything seems to be complicated by past COVID infections. And yes, it is viral, but there are complications in this post-viral world with bacteria as well. And the picture just gets muddy with that. Any thoughts on that as a parting talk, and any thoughts on AI in this field?
Yeah, so all of those are questions right on point. So to answer your first question, I would be delighted, absolutely delighted to come to the next meeting in 2026. I am very interested in building close ties with India, partly because I am Indian and partly because I have a very, very high opinion of the technological prowess and the clinical prowess of the Indian system. So very interested in that, and so please count me in. The answer is yes already. I know I haven't gotten an invitation, but the answer is yes.
Definitely, we'll get an invitation.
Yeah, the two other questions were great. So I don't know, maybe you're reading my mind. We have gotten very interested in post-COVID diseases for multiple reasons. And I think one big reason is that COVID is, because it was a new virus, it causes such massive immune activation. And we think that a lot of the post-COVID syndromes that are occurring are because of massive immune activation. Obviously, there's data that it causes post-COVID pneumonias, so Klebsiella pneumoniae, also lots of data on invasive mold infections in patients who got COVID. And so I think it's not just COVID. I think viruses in general are very interesting to think about in terms of what they can do long term. One, obviously, they can predispose to several other bacterial and fungal infections. I think that's kind of known, but maybe COVID made it very clear cut. The second is the immune responses that are occurring with viruses, but also other infections. And I think COVID brought that to attention, and not just in the area where they caused infection, but systemically. I think a lot of post-COVID syndromes, including issues with brain disease, and I mean, we've seen a lot of patients have substantial dementia, just during this period, and we don't know the exact mechanism. So that is going to be a fascinating area to explore, not just for COVID, but COVID being obviously a clear reason why we need to think about it. AI, very interested in AI. In fact, some of the ways that we think that target to non-target ratio and more, people use SUV, but, automated segmentation of tissues as well as calculating target and non-target ratio. We're very interested in AI to do that. So I think AI is going to be very useful for image analysis. Absolutely.
Yeah, because we're also establishing some tie-ups with, from Mallinckrodt, we have endogenous AI expert, Dr. Jha, who's, going to try establish collaboration with India for AI work, and we can all tie up that together through IASNM. So I'll contact you individually, and I'll make sure you get an invitation for next year.
Thank you so much. I really appreciate it.
Yeah, this is Jyotsna. Yeah, thanks a
Hey,
lot for the
Jyotsna.
excellent. Yeah, hi. So thanks a lot for the excellent talk. And as Amol was saying, we are going to have our Federation of Asian Society of Molecular Imaging meeting in Hyderabad next fall. We are planning all of that. And as president of MISI, I would love to have you. I'm actually love to have you in Hyderabad if you can come. So we haven't formed the academic program yet. We are all going to sit down and do it. And this would be of great use, actually, infectious diseases talks, because you've seen how much interest you generated. So we'd love to have you there. Uma, what do you think, Uma?
You're muted.
Absolutely. I think there is a lot of interest in infectious disease, and I think you gave a new dimension. I think I, for one, had been, it was a learning experience, because most of the research that I came across were more focused upon therapy, addressing multi-drug resistant. AMR is a big thing, especially in India. And I think the prospects that you brought in actually can change the way we are even going to look at how drug therapy is effective or ineffective. I think it's amazing. And I would second Dr. Jyotsna. I do look forward to you visiting India and talking and motivating more people, actually, to work in this domain.
I really appreciate that. Thank you, Jyotsna. Thank you, Uma. That's very nice. And my answer is absolutely yes. And I look forward to it. I'm fascinated by the work that's being done there.
Yeah, and actually there's the cost factor too, because many people can't afford the drug therapy, long-term drug therapy. If you can actually tell them if it's working or it's not working, it'll be really helpful in terms of cost and side effects.
That's a good point. Very good point there. Yes.
I think another country to collaborate would be South Africa, because they do a lot of work on this as well, including TB.
Oh, absolutely. Yeah, there's a lot of collaboration with South Africa. I think South Africa is a little bit different because majority of, let's say, the TB epidemic is being driven by HIV. India is a little bit different from that point of view. But I'll also tell you, funding has become very interesting. Very difficult to get funding now to work in South Africa from the NIH.
Yeah.
Not so much with India. India still is on the good books right now.
Awesome. Thank you again for a wonderful talk. I think, Uma, we're beyond time, so let's wrap it.
Yeah.
Absolutely.
Okay.
Thank you, everyone. I think it's wonderful.
Bye. Bye, Amol.
Bye, Jyotsna.
Bye.
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 Thank you.
Bye.
Thank you, everyone.
Bye. Yeah. Bye.